Thank you, Rachel, for this opportunity, and the other organizers and all of you who've stayed in to hear our remarks. I'm going to move along very briskly, looking at new and emerging lipid-lowering drugs, specifically related to secondary prevention. Here are my disclosures. First, I'll talk about LDL reduction. That's the primary target based on observational data and randomized clinical trials. And I'll look at safety and efficacy of the approved agents and emerging agents. And then, of course, for this Congress, I would highlight special considerations related to sex, gender, race, and ethnicity. Unfortunately, time does not equal progress. This is from American Heart Association, Hard Facts and Statistics, the latest national data. Cardiovascular mortality rates are actually increasing in the United States. And there still is a white-black mortality gap. This is not social science. We're not talking about a bad Twitter or Facebook post. We're survival itself. The life expectancy of non-Hispanic black males is the shortest compared to non-Hispanic white males. And non-Hispanic black females have a shorter life expectancy compared to non-Hispanic white females. If you look at the gap between white females and black females, that gap is larger than the gap between black females and white males, such that being a black female almost removes the protective effect of being female. In the longevity of Hispanic populations, remember these are very blunt terms and we need to disaggregate this term Hispanic going forward. But looking at the national data, the way it's accumulated, the Hispanic population does not appear to have shortened life expectancy. That all changed with COVID-19. Here's the data. Going back to 1980, you see the white-black mortality gap. It actually started to narrow somewhat, but with COVID-19, the mortality has now widened again. And any protective effect in terms of longevity of being Latino or Hispanic has been removed. So again, time is not necessarily progress. We're talking about mortality. I'm going to talk about pharmacotherapy, but we must remember we're talking about people. This is publicly available from the Wall Street Journal. We see this woman peering out of the window, her husband dying suddenly at age 49. You can see the intense misery and suffering that comes along with premature cardiovascular death. This cartoon comes from Brunwald's chapter. It has not yet been published, Ferdinand, Bond, and Reddy, and we looked at what are some of the factors that contribute to these disparities in race, ethnicity. There may be some inflammatory markers. I'll talk a little bit about lipoprotein (a) and continent of ancestry has some degree of a difference. Levels of PCSK9, there's some data on that. But I think overwhelmingly the driver of disparities are the conventional risk factors. The things that we need to control that really affect cardiovascular disease, hypertension, smoking, unhealthy diet, hyperlipidemia. Here's a cartoon again from that same chapter, which will be published soon, looking at a balance beam. While genetics and biology may play some component of it, it's weighed heavily to the social determinants of health, the things that we've been talking about this morning and their effects on cardiovascular disease. Now, when we go forward, I'm going to talk mainly about secondary prevention. Primary prevention is another talk, but I think it's important that we also describe who are the patients that I'm talking about. I'm mainly looking at the very high-risk patients. This is from the guidelines. They've had multiple major atherosclerotic events, or they've had an event and they have an additional risk factor. And if you look at the additional risk factors, those are the things that we see in cardiology clinic most of the time. So many of our patients, if not most, will be very high risk. The conventional lipid-lowering therapies, which are now available, first are the statins, the HMG-CoA reductase inhibitors. That is the rate-limiting step of the synthesis of cholesterol in the liver. If you block the synthesis in the liver, you upregulate the LDL receptors, so the plasma LDL falls. We also have the bile acid sequestrants. They're not used much now, and ezetimibe, which blocks the absorption of cholesterol in the small intestines. We have data adding ezetimibe gives you an additional 10 to 15, as much as 20% LDL reduction. And we've had approved the PCSK9 inhibitors. This blocks the disaggregation of the LDL receptors within the liver such that the LDL receptors can go back to the surface and pull more LDL into the liver. Now, I'm going to look at the data on the new and emerging agents, but I will give you this warning. Almost all of the data has been done in non-Hispanic whites and predominantly males. Even looking at ezetimibe, which is now generically available, I use it all the time, the study on which it showed its outcomes benefit was 84% non-Hispanic whites, 75% male. Here's the statin data. I will not go through each trial. The green trials are the placebo-controlled trials. That's been done. One way to communicate to patients the importance of treatment, and I do this on a regular basis, I'll say, for instance, if they have hypertension or they have elevated LDL with secondary prevention. We have done the studies. We have taken people who've had disease states like you, put one group on this medicine, put another group on placebo, the sugar pill. The people on placebo have more heart attacks, strokes, and die. I don't want you to be in the placebo group. And they get it. Most patients get it if you describe to them exactly what evidence-based medicine is. There are also statin trials that have now shown that intensity makes a difference. If a person can tolerate it, high-intensity statins for secondary prevention has better benefits than just a little bit low or moderate intensity statins. There are also newer agents such as bempedoic acid. I'll describe this in some detail, but its cardiovascular outcomes is not available. It works similar to the statins, and I'll describe why that's an important consideration, because it may have some tolerance that statins may not have in some patients. And the PCSK9 inhibitors have at least a moderate reduction in cardiovascular outcomes. They add another 40 to 50 to 60% LDL reduction. The problem was the barrier, the cost with the PCSK9s, and I'll address that also. And I have there Inclisiran, and I'll describe to you what that particular moiety is. Let's go back to the liver. The liver is the central way in which we affect some of these agents. Looking at the bempedoic acid, it works upstream from the HMG-CoA reductase inhibitor. So before you get to the action of the statins, the prodrug, bempedoic acid, acts in the liver to decrease the formation of LDL cholesterol such that the LDL receptors are increased. This is basically doing the same thing, but it's one step before the statin. Inclisiran works similar to the PCSK9 inhibitors, but the PCSK9 is a monoclonal antibody in the serum, whereas Inclisiran works as a small interfering RNA within the liver itself, so it blocks the synthesis of the PCSK9. By blocking the synthesis, then, it causes a robust lowering of the LDL cholesterol. It does not have cardiovascular outcomes. It is approved in Europe and will probably be approved in the United States sometimes next year. I'll also mention very briefly the PTL3 inhibitor. We're not really sure exactly how it works, but it doesn't work through the LDL receptors. It works through inhibiting lipoprotein lipase, which is an enzyme. If you inhibit that enzyme, you don't make as much triglycerides and LDL cholesterol, and that has been approved in the United States. This is from a review of women and older participants in randomized trials. I'm not going to go into great detail, but I'd like to show this because Aaron Mikos was the senior author, and they did a systematic review of over 485,000 patients. And what they showed was, considering that women have a large burden of cardiovascular disease, there's only been a moderate increase in female participation in clinical trials in cardiovascular disease over the last several years. Hypercholesterolemia itself, probably because some of the statin trials did have significant numbers of women, do have more representation, but other conditions which are disparate in women, diabetes, heart failure, stable coronary disease, acute coronary syndromes, have underrepresentation. This is the guidelines. It's a 2A. It says, consider race ethnicity when making decisions on statin therapy. Now, race is a social construct. There's no biology, there's no genetics for race. It's a description that we give of people in terms of how they look. It's a very blunt tool. I'm not ready to abandon it because it may help us find deficiencies in how we deliver care. And if we just say, well, we're going to forget about race, we're all the same, you know, everyone's 99.9% the same by the human genome, that's true, then we're not going to really recognize the white-black mortality gap, the lack of equal application of evidence-based medicines, the mortality, the infant mortality, the pregnancy-induced mortality. Those things are not going to go away simply by disregarding race. Race may also be a very poor surrogate, but have some validity for continent of ancestry, and I'll show you some disease states that may support that. This is directly out of the guidelines. Their words, not mine. First, in terms of lipids, the first box are Asian Americans, tend to have lower levels of HDL, higher levels of LDL. The middle box, Hispanic Latinx, especially Hispanic women, tend to have low HDL. That's a component of the metabolic syndrome, abdominal obesity, elevated triglycerides, low HDL. And in the African American population, we actually saw this in MESA. They tend to have higher HDLs and lower triglycerides. Now, this might be related to some differences in continent of ancestry. NIH has looked at these data and suggests it may be related to lipoprotein lipase. If you have high levels of that, you tend to have higher HDLs and lower triglycerides. And you'll see this in your clinic, an African-American patient, a black woman who may have obesity, may have even had a heart attack, but the HDL is 50 and the triglycerides are 75. It's misleading because we know this is a high-risk population. Asian Americans may be more sensitive to statins. This is actually in the labeling. If you look at the bottom of that box, the FDA recommends starting rosuvastatin at 5 milligrams in Asians versus 10 milligrams in other populations. I don't necessarily adhere to this. It's based mainly on looking at blood levels of statins. There is a trial with pitavastatin using high-intensity statins in the Japanese population, and it does show benefit. So if the patient can tolerate high-intensity statins, regardless of self-defined race, ethnicity, I think that's your target of therapy. The other box at the bottom are blacks with CK levels. Some of this research I did when we were studying rosuvastatin, we noticed that the self-defined black patients tended to have higher CKs, mainly big men. You have to be very careful using CK as a sign of myopathy. I actually don't measure it. If you measure it, you're going to find patients who have elevated CK. If you didn't get baseline, you're going to think it's caused by the statin. Unless it's markedly elevated with symptoms, it is not a sign of myopathy. I said in my opening remarks, I'm going to focus on LDL as the primary target. Just as an aside, there is a new agent that looks at triglycerides, Icosapent ethyl, and it's type of a refined fish oil, and it has shown remarkable decrease in adverse cardiovascular events, statistical significance, p-value less than 0.001, 8,000 patients, robust data, but if you look at the bottom of the slide, 72% male, 90% white subjects. Doesn't mean you don't use this agent in a diverse population. It just means that the data, again, has a blind spot. There's a problem when you have a blind spot in data and you do a subgroup analysis. Sometimes you find quirky things. And what I tell my friends in industry is if you're going to do a study, either have a robust, diverse population or don't do it. Because if you don't have an adequate sample size, you may find something like Icosapent ethyl doesn't work in blacks, it doesn't work in Asians, it doesn't work in Hispanics, which may not be true. It could be what's called a type 1 error where you didn't have enough power. Let's look at the PCSK9 inhibitors. This is an analysis I did of the 3 ODYSSEY trials. And unfortunately, again, looking at the sample size, they're underrepresented for African American or black or for Hispanic Latinx. But lucky for them, despite that, there was no p-value of an interaction based on race or ethnicity. So I think the PCSK9 inhibitors will work across a wide range of patients. The major outcomes trials, this is alirocumab. Again, look at the sample size, 25% female, 80% white. Fortunate again for them, and that's a gamble. When you have a small sample size, you don't have a representative sample, you can always get quirky results that go the wrong way. In this particular case, there is, again, no interaction based on race. The small box, the African Americans, that's called a box and whiskers. The big whiskers means that you really can't have much confidence of what you're looking at because the sample size is small, but at least the trend goes the right way. I would see no reason why a black patient would not respond well to PCSK9 inhibitors. Here's another one, evolocumab. The first that I just showed you was alirocumab. This is evolocumab, its cousin. Again, small sample sizes, mainly male, mainly white identified populations, but no p-value for interaction other than a slight trend towards what they define as non-Caucasian, which is not a term of art we should really utilize, and we can talk about that in questions and answers. But the trend is for the here defined as non-Caucasian populations to do well. That might be because lipoprotein little a is decreased 20% with PCSK9 inhibitors, and it tends to be higher in African descent and South Asian descent patients. Don't really know that, but that might explain why there would be a trend towards a benefit with the PCSK9 inhibitor. Here's what I think is the big problem. The big problem is not whether or not we do a clinical trial and we show good results, because we've shown data that that can be done. It's what happens after we have these medicines available. I still have clinic 2 days a week, and patients struggle to get especially newer medications. This is research done with the PCSK9 inhibitors, and what it showed in a large cohort is that those patients who were either rejected from getting it because of prior authorization, or if they abandoned it because of the cumbersome of getting the drug, had an increase in cardiovascular outcomes. So if the medication has benefit, there is a cost in not making sure that the medication is available. The plot thickens. Those patients within this large cohort who are all high risk, who had the worst outcomes and more rejection of the PCSK9 included women, members of racial populations, and lower income groups. It's the same story, different disease. Here we're talking about PCSK9 inhibitors. These are the social determinants of health. These are the barriers to evidence-based medicine. I mentioned bempedoic acid. It is approved in the United States. Here's the cartoon showing where it works. HMG-CoA reductase is in the middle. ATP citrate lysase is one step above that. That's where bempedoic acid works. So what's the benefit of blocking the synthesis of cholesterol in the liver one step before the HMG-CoA reductase? The benefit may be that in order for bempedoic acid to get its effect in the liver, it has to be changed from a prodrug to an active drug, and that particular conversion only happens in the liver and not in the muscle. So it has no effect in terms of some of the myopathy, myositis that we see with the statins. Here's some of the data on which it was based. Again, male sex, 70%. White race, 95%. Doesn't mean it's not a beneficial agent. It just means that the studies were done in a population which was skewed towards maleness and towards white self-identification. It was approved by the FDA in 2020. Most of us didn't pay attention because there was this little thing called COVID-19 that was starting to hit the world. And the FDA gave it approval to diet and maximally tolerated statin in patients who have heterozygous familial hypercholesterolemia or who have established ASCVD and require more drug treatment. This approval done in the United States was given in a 95% mainly male white population. Doesn't mean don't use it. It just means that the data on which it was approved is a little bit less than we would like to see in terms of trying to apply a new agent across a diverse population. Here's their forest plot. Looking at its benefit, you can see race, mainly white. You can see sex, mainly male. Fortunately, fortuitously, there does not appear to be a adverse interaction based on sex or race. So again, the agent probably works, but we just don't have the data that is as robust as I would think would be optimal. Here's another agent. This is Inclisiran. Remember, the PCSK9 inhibitors block the degradation of the LDL receptors by blocking PCSK9 in the serum. It's a monoclonal antibody. It's kind of similar to what we do with COVID-19 monoclonal antibodies. In fact, the same company that made one of the PCSK9 inhibitors, I'm going to be a little bit facetious here, but not much, couldn't get the uptake with the PCSK9. They turned their manufacturing to monoclonals against COVID-19. Inclisiran is not a monoclonal antibody. It silences the mRNA within the liver, but it works through a similar pathway. And I'm going to talk a little bit about antisense oligonucleotides. That's another way of blocking the making of a drug, and they do this within the liver, and it's for Lp(a), and I'll talk about those two things. Inclisiran is really interesting. It's approved in Europe because it works like a PCSK9 by increasing the LDL receptors, but it only has to be given twice a year, because when you turn that signal off with the small interfering RNA, it has a long-lasting effect. So versus the PCSK9 inhibitors, which are every 2 weeks, every month, Inclisiran is twice a year. Its placebo-controlled effect on top of high-intensity statin is 50%. Very robust LDL reduction. That's in addition to the statin. The p-value is very significant, and the safety was similar to placebo. Here's the problem. Large population, Inclisiran versus placebo, almost 70% male, 92 to 93% white race. Doesn't mean it doesn't work in a diverse population, but again, the study is not representative of what we would like to see when this drug is approved in the United States and we start to apply it widely. ANGPTL3 is a monoclonal antibody. It blocks lipoprotein lipase breakdown. Remember, lipoprotein lipase is good. It might be one of the reasons why some people of African descent tend to have high HDLs and lower triglycerides. So you want to block that degradation, and that's what ANGPTL3 does. It's been approved for monoclonal antibody treatment of patients with homozygous FH. Those are going to be young people with very, very, very severe elevations of LDL cholesterol. It has been approved in the United States for homozygous FH, but the population was mainly non-Hispanic white, mainly Afrikaners from South Africa. A few words on PCSK9 inhibitors and its relationship to the Lp(a). Lp(a) comes out of the liver. PCSK9 inhibitors also block the formation of Lp(a) or the breakdown of Lp(a). If you look at Lp(a), it comes out of the liver, it goes to that cartoon, the carotids, the coronaries, the aortic valve, and it does appear to have some differences in continent of ancestry. Now, continent of ancestry is not the same as race, but it tells you that there may be some factors that some populations have that are different from others. And if you look at the percentage of Lp(a) in persons of African descent and South Asian descent, there seems to be a higher population. So what's now being developed, and this is only research, this is not approved, there are no outcomes, is using antisense oligonucleotides where you block the formation of Lp(a) in the liver, and you can get sustained reductions in Lp(a). Thus far, the data that's been accumulated, over 95% non-Hispanic white subjects, which is a little bit funny because if we talk about the population that has probably more Lp(a) as predictive of disease, it would be African Americans and South Asians. So where are we going forward? Well, we need to overcome these barriers. ACC has made a commitment to that. American Heart Association has made a commitment to that. The American Society of Preventive Cardiology also has made a commitment. Again, I'm showing another publication from Dr. Mikos, and I was the senior author. This was shown earlier in terms of the application of wider use of women in clinical trials, but there was also a part of that same publication that looked at racially, ethnically diverse populations. And here's the idea. If you have underrepresentation, then you will have underreporting of a benefit. It will limit the generalizable ability of the particular agent. It's going to be hard to say, yes, this agent's really going to work really well in you, Mrs. Brown, although I know you went on the internet and you looked up the study it was based on and you weren't in it. So you want to be able to say that this agent works well across all populations based on the research. This may then become a barrier. The barrier is also driven by finances, and we discussed that. And one of the ways to overcome this is to increase diversity in studies. You saw this cartoon earlier, and I'll bring your attention to it again. This side looks at the improvement in enrollment in women. It talks about being flexible, the hidden costs of the caretaker, the woman who's working and has children not being able really to take time, educating the patient, having inclusive criteria, and making an attempt to include women. And in terms of racial ethnic minorities, if you, the investigator, doesn't represent that population, that's fine. We know everyone can't be of all groups. Have a representative staff, have people from the neighborhood who work in your office. I have an inside joke. You will spend 30 minutes with a patient trying to get them to enroll in a study or adhere to a new therapy or get approval for a surgery. They will go outside, lean over, and ask the Hispanic, Latinx, or the African-American front office, you think I ought to do this? Is this a good doctor? And that opinion has a lot of weight. Diversify your sites. Make sure you have language-appropriate, culturally appropriate information. So overcoming these barriers for lipid research, infant mortality, pregnancy-induced, we can talk about certain cancers, diabetes, it's a wide range of conditions, but here I'm talking about lipids, needs to have targeted efforts. It's not enough just to say we treat everyone the same. We need to help to make sure that we have diverse cohorts against these agents or with these agents using sex, gender, race, ethnicity. And my final bullet point, health equity is a moral, practical imperative. This is not just about name calling or changing the window dressing. In order to prevent and reduce these disparities, we need to make sure that everyone has access to the best evidence-based medicine regardless of sex, gender, race, ethnicity, socioeconomic status, or geography. Thank you.